Now, one of the biggest errors that we make is trying to fit what we think into fit that data to our hypothesis rather than fitting the hypothesis to our data. So, in the very beginning, as we are formulating our notes, this is one of the reasons that obtaining an accurate history is so incredibly important. You may find clues from your history that actually help you fit that peg in the hole that you may not have considered otherwise. So gathering all of the appropriate information is key. In fact, I would have to say that those who have a great skill of obtaining a good history are some of the best providers. And I use myself as an example. When I was much younger, I had gone on a camping trip and I came home and I had awful stomach upset and chronic diarrhea, massive weight loss. I was in my mid 20s at the time. I went to one doctor, was hospitalized. They did every test under the sun on me, couldn't find other than I had an inflamed gallbladder, sent me home. I was in the hospital 3 times that summer. Finally, I went to a different provider. Now, the first visit I had with that provider, she sat with me face to face and interviewed me for 1 hour. 1 hour. That's a long time. And during that interview, she asked the magic question, "Have you been camping recently?" And I said, "Yes." And would you know, I found out I had gotten a parasite on the camping trip, Giardia. I was treated and I was fine. But I like to use that case as an example because as a patient, I was searching to my provider who I trusted for answers. And I thought that he was giving me those answers. Finally, it came to a time where I said, "Oh no, I have to, he's not, I know that I'm sick and I've got to find out what's wrong with me." And fortunately, I met somebody who actually listened to me and asked the right questions. And I want you to be that type of a provider. Now, generating a differential diagnosis, this is putting together a list of possible conditions that may be responsible for the patient's signs and symptoms. It's part of clinical reasoning and it enables appropriate testing to rule out the possibilities and confirm a final diagnosis. The list is often prioritized by likelihood and urgency. And in a court of law, courts view the formulation and documentation of differential diagnosis as evidence that the provider has competence, prudence, and thoughtfulness. So it is an important key to your documentation, not only in getting toward the right diagnosis, but also if you had a case go to court, it looks as though you do have a strong background and you're following the proper steps of for a diagnosis. When you've eliminated the impossible, whatever remains, however improbable, must be the truth. Is that true? Well, I like to tell new providers, and I still live by this rule, I always take the worst case scenario. So if a patient comes into my clinic and they're a teenager and they have a fever and a stiff neck, they have meningitis until I prove otherwise. So I have a case later on that will illustrate the importance of always thinking worst case scenario. So here's one. Here's my worst case scenario patient. An obese Caucasian male, history of high blood pressure, smoking, has severe low back pain for 4 days. He has occasional vomiting. It radiates to both lower quadrants and has an increased severity of back pain. It awoke him this morning, so he went to go see his doctor. The vital signs are normal except for mild elevation of the systolic blood pressure. The nurse practitioner assesses the patient and finds no significant physical abnormalities. The femoral pulses are strong and symmetrical. A flat plate x-ray of the abdomen is read and later confirmed as normal, and a complete blood count was normal. The preliminary diagnosis by the nurse practitioner was musculoskeletal back pain. Narcotic analgesics were administered. Now, this patient was hospitalized, so at shift change, the patient's care was transferred to a different nurse practitioner, reviewed the patient, and agreed with the diagnostic impression of mechanical back pain. That nurse practitioner discharged the patient with a prescription for analgesics and the instruction to find a family doctor for follow-up care. 2 days later, the patient was found dead at home. An autopsy revealed a ruptured abdominal aortic aneurysm with 3,000 cc's of blood in the retroperitoneal space. The patient's family threatened legal action, alleging failure to diagnose the condition and failure to provide adequate discharge instructions. Now, what does this case tell us? I don't see any evidence of a differential diagnosis, and you want to consider abdominal pain in an older person with his history is an abdominal aortic aneurysm unless it's identified otherwise. So is this something that we would have ordered an abdominal ultrasound for? Yes. I think sometimes nurse practitioners may be fearful of ordering too many tests. And I must say, I'm sure early on in my career, I ordered many tests, many more tests than I do today. But now I have gained the experience, so I know when it is appropriate and when it's not appropriate to order a chest test. But I still will always err on the side of caution. Now, a leaking AAA can mimic renal colic, back pain, diverticulitis, gastroenteritis. In particular, AAA might be considered in the differential diagnosis of an older patient with symptoms suggestive of renal colic. Severe radiating pain is a common symptom. Syncope and vomiting may also be associated. A patient with persistent symptoms may warrant a new evaluation as appropriate. Alternative diagnoses include the worst case possibility should be considered. So AAA should definitely have been in the differential. And when that other nurse practitioner came on board, she was almost too easy to accept that other nurse practitioner's diagnosis. So did she examine the patient? Did she do anything to identify whether or not the initial nurse practitioner was on the right track? Or she just trusted her judgment? I don't know if that's a good practice, because she is the nurse practitioner that's now assuming care of that patient. Patients with pain require analgesia, even if appropriate doses of narcotics control the pain. It can be prudent to review the patient to determine if the diagnosis is masked by analgesia. So we want to reassess that patient. In appropriate clinical circumstances, the medical record should indicate the diagnosis with the worst prognosis. In this case, AAA was considered and was pursued if reasonable to do so. So the rationale for not investigating should always be clearly documented. So I will write that. Now today, in our day and age of electronic documentation, there are cases I will write in the discharge instructions, or I'll write in the summary note why I haven't done a specific thing. So the American Academy of Pediatrics recommends that a throat culture be done on children who test negative in a rapid screen. Well, sometimes the parents say no, they don't want it, or they don't have insurance and they can't afford that $110 cost. So I will document it. Parent denies need for send out throat culture, no insurance, unable to pay, something like that. Leave it to the facts. You don't want to put in there, oh, the patient was yelling and screaming and saying that they didn't want the throat culture. Parent states, or parent denies need for send out throat culture. Bam, that's it. Keep any of the subjective stuff out of it. Clear, concise, and objective. All right. The presence of a certain red flag. Findings may prompt experienced physicians and nurse practitioners to accept or rule in a serious specific diagnosis. Yet even experienced physicians and nurse practitioners are often surprised by the range of symptoms and signs of disease. So we always have to try and go back to our basic. Okay, I missed a slide. History taking. In legal action, peer experts are going to look at your chart, make sure that you take an adequate history, of the patient's health concerns, provided the patient with the opportunity to express about their concerns, identify language barriers, who you consulted to help with the history. We've got wonderful language lines now and many methods, so use them. Remember, err on the side of caution. If you're having difficulty communicating at all, use a language line. Look for relevant risk factors like family history. That's a big one, I think, in the acute setting for me with asthma. Are there any red flags? Have you determined what the patient has already done to manage their symptoms? If assessing a patient over the telephone, have you gotten a good history? And I frown upon that. If you've read the notes taken by another, have you read the notes by other providers? Are pertinent medical records, test results, and consultation reports available? Have they been reviewed? The physical examination. In legal action, peer experts will be critical if they consider that the physical examination has been cursory to the patient's symptoms. Have you performed an appropriate physical examination? Now, you need to perform, when you're performing an exam, you need to, any body system that's been mentioned in the chief complaint, the history of present illness, needs to be listed in the review of systems. Has to be examined, and you need to document that you examined it. You need to take vital signs and account for any abnormalities. If I have a patient come to my clinic and they're on antihypertensive meds and their hypertension is high or their high blood pressure is elevated, I have to make note of it. I have had patients where I call their physicians because of situations that have seemed out of sync, especially with the geriatric population. If I have a patient who comes in, looks nice and healthy, no history of anything, and they have hypertension, I will diagnose them with elevated blood pressure reading without the diagnosis of hypertension and then send them for an evaluation. Assess the patient appropriately for the clinical complaint. And make sure you're doing a complete exam. Something that gets me with providers is when they're listening to the chest, they aren't listening on the skin. You have to really listen to the skin to get a good reading of the lung sounds and the heart sounds. And to avoid misunderstanding, explain why you're doing these particular exams. Do you need a chaperone for intimate exams? Explain what you're doing to the patient. And then you want to, when you're documenting, you want to include that you explained it to the patient. Now, differential diagnosis. This is a list of possible conditions that can produce a patient's symptoms. And it's an important part of clinical reasoning. So now, up to this point, you have gathered many clues. So I say this over and again. My students probably get annoyed by it, but I like to think of a visit as a CSI investigation. So the patient comes in and they present with all these symptoms that are my clues. And now I have to take all those clues and perform any testing that needs to be done and come up with the best explanation as to what's causing their symptoms. Many serious disorders are challenging to diagnose. Have you considered ruling out the worst case scenario? As a medical student or a nurse practitioner student, have you discussed possible diagnoses with your, it says supervisor here, but what about a peer? Do you have a mentor? If you're a new grad, you're going to have a collaborating physician. Sometimes you want to discuss a differential diagnosis prior to having it entered in the medical record by a student so that you're on the right track. Formulating a diagnosis. Relying solely on the classic features of a disease can be misleading because the clinical presentation of a disease often varies. You can have left shoulder pain and you can have a gallbladder going on or pancreatitis. You need to have a sufficient understanding of the clinical presentation. What could it be? And I say this often to patients, especially with skin disorders, because skin is one of the most difficult and challenging things to diagnose because so many of the different inflammatory or processes look similar. So I tell my patients, I'm formulating a differential diagnosis on you, and that's the top 5 things it could be. I use my expertise and I use what you tell me to come up with the best case scenario here for what it could be. And I do them in list of order of what it is most probable and then to least probable. And I tell the patient, right now it looks like more than likely it's this one. Let's say contact dermatitis. So we're going to treat it with this and this. And if there's no improvement in your symptoms in 5 days, or if at any time your symptoms worsen, then I want you to come back. We're going to have to reevaluate. So I'm not going to just look at my notes and say, if they come back and say, oh, well, it must be number 2. Things could have changed by then. So I need to completely reevaluate the patient to see whether or not those differential diagnoses that I chose are still applicable. Sometimes you may want to consider using a diagnostic decision support tool. And there are some in professional organizations. For example, let's see, the Society of Infectious Disease, they have an algorithm. So if a patient has bronchitis, most of the time you don't treat them with antibiotics because it's more often than not viral in nature. However, there's an algorithm that you can go through to identify if or if not the patient should be treated with antibiotics. Also, there's one for sinusitis, a whole host of different algorithms you can find, and you may find those helpful, especially in the beginning. Does something in your gut tell you that there's something going on with your patient? Always trust your gut. All right, so now you may not have a whole bunch of tests to do. For example, in my setting, I only have point of care testing. So I can test someone's urine. I can test for strep throat. I can test for, I can test A1C. I can test their cholesterol. I can test their blood glucose. I can test for mononucleosis. But other than that, I'm going to have to send them out. So is my setting appropriate for what they're presenting with? So if I have a patient that I think really needs a chest x-ray, I send them someplace where they can get that chest x-ray because I'm not going to be doing a service to them. Always be familiar with the current clinical practice guidelines. They change. When I first became a nurse practitioner, amoxicillin was the first line drug of choice for sinusitis. Now, due to antibiotic resistance, it is no longer. So you have to keep up with that stuff. And have you requested the appropriate investigation? What does that mean? Have you ordered the right test? Is it available in a timely manner? Are there any alternatives? Does your completed diagnostic imaging requisition contain pertinent clinical information to help the radiologist? So if you suspect something, I once had a patient that I suspected had pneumonia, so I sent over for a chest x-ray, and on my requisition, this was before we had electronic medical records, on my requisition I wrote down what I suspected and what I found on the examination. So then when the radiologist read it, he addressed those points that I had made on the requisition. Could the patient be pregnant? I always consider that too with young women. If you're coming in with abdominal pain, or you're coming in with, you think you've got a UTI, I test your urine to make sure that you're not pregnant. In all my years, let's say I've been a nurse practitioner for about 10 years, there has been one patient I tested who was pregnant. The rest have been negative. But it's important to note because what's going on? Are they having issues? Are they cramping? Are they potentially having a miscarriage? Also, if they need medication, if they do have a UTI, I have to ensure I don't use Cipro or Bactrim on a pregnant woman. They have to go on Macrobid. So consider pregnancy as well. Here's another case study. A 35-year-old woman presented with recurrent crampy abdominal pain that's been occurring over the past several years. This pain has become increasingly severe and debilitating over the past few months. It's usually relieved by a bowel movement. She has a pattern of intermittent constipation and loose stool. She denies blood in the stool, and the pain tends to be diffuse in nature and seems unrelated to diet, exercise, and or stress. She's new to this practice. She moved to this region only recently because of her husband's job. She stayed with the same firm, but it's a new location. I want to find out what is wrong. That's the CC. So when you are recording what the chief complaint is, it's usually just a few words that identifies what brought the patient into the clinic. I'm tired of always worrying about where a bathroom is. Now, these cases I wanted to interject here are real. I get these cases. I utilize, if you're familiar with NSO, malpractice insurance, they have a wonderful site that has all sorts of real cases involving nurse practitioners, and that's where I get my cases, in case you're interested. I'm interested. I didn't make them up, and they're not mine. The physical exam revealed an essentially normal abdominal exam, an overall negative exam. The stool was negative for blood and mucus. The patient is of normal height and weight, does not smoke, drinks only socially, has a good job, denies excessive stress, married without children, no recent weight loss. What additional data may you need from this patient? What laboratory tests do you need and why? What is your list of working diagnoses? What plan of care would you devise for this patient? And what follow-up is needed? What patient education is important? Health promotion strategies? What complementary therapies may be helpful for this patient? And these are questions that you should ask yourself on every patient encounter that you have. An 18-year-old woman presents with new onset abdominal pain, nausea, and vomiting over the past 18 hours. She's accompanied by her mother. She's tearful and in distress. This patient is not new to your practice. You've followed the entire family for years. Her CC, the pain is getting worse. The physical exam displays a blood pressure that's normal. Her heart rate's up a little bit. Respiratory rate's up a little bit. She's got a low-grade fever. Pale and in acute distress, guarding. She's average height and weight. Pain is peri-umbilical, some right lower quadrant tenderness with rebound. Denies pregnancy, denies sexual contact. Questions. What other data do you need to diagnose this patient? Would you do a gynae exam and why? What laboratory tests are important and why? Imaging and why? Do you need a surgical consult? How many patients diagnosed with appendicitis in actuality have this condition at the time of surgery when the appendix is directly visualized? What are potential complications of this problem, and what is the plan of care of this patient? So patients who present, these are the questions that you're going to begin formulating every time you have a patient encounter, as you did with the prior patient. Now, this one seems a little more clear. It looks like a hot appendix because of the rebound tenderness. How are you going to diagnose it? What are you going to do? Usually, an abdominal CAT scan is going to be proof positive that they have appendicitis. But you may want to do a CBC. I mean, there's a whole list of things that you're going to do in the emergency department if someone presents with these symptoms. Another case study. 45-year-old man, 3 days of rectal bleeding. The blood's bright red. Seen it in his stool as well as tissue. There's some pain when he passes a stool. The patient and his family have been part of the practice for years, but hasn't been seen in a long time. So he says to the provider, do I have cancer? Here's the physical exam. It's pretty normal. Okay. The digital rectal exam was a little painful, and the stool was positive for blood. Abdominal exam was negative. No history of weight loss. No family history of colon cancer. No history of bleeding before this episode. Questions. How do you distinguish between a straightforward case of hemorrhoids versus a potentially life-threatening colon cancer? What things in the history are important to establish? How do you proceed with additional testing? What is your plan to care for this patient, and what complementary therapies may be appropriate for long-term management? These are some questions I want you to start thinking about if you have a patient that presents with these types of symptoms. The one red flag for me is he said, do I have cancer? So that's a concern of his. And it reminds me of a case. I wasn't involved in it, but it was at a legal seminar I was at, and actually I use it in one of my other presentations. The patient came to the physician's office and requested a PSA. So he wanted a prostate blood test. The physician said, "Why do you want to do that?" "Well, I'm worried I may have prostate cancer." Well, the physician said to the man that there's a very low probability and that the risk has a high false positive rate. So he doesn't routinely do it on patients, did not do it. A year later, the patient was diagnosed with prostate cancer and sued the provider. So that could have been like eliminated if the physician had listened to the patient and had just done the PSA test. So listen to your patients and what they tell you.